Good Saturday morning at VAM. Ladies and gentlemen, thank you so much for waking up this morning to join us for this session. This is a really unique session that has been put together. I want to thank the SVS for their foresight in bringing together a really unique session for us to talk about a challenging thing, which is how we talk about this disease of chronic limb-threatening ischemia with our patients, how well we are doing with helping them understand the process, the disease, and the choices of treatments that they have. We recognize that this is a big challenge that we all face in our practice every day. And we've tried to put together a really interesting session for you to really discuss different ways of approaching this challenge. And we are really fortunate to have 3 patients from the Chicago area that we'll introduce to you later who are here with us to share a little bit of their experiences with how they digested the issues that they were facing when they first were diagnosed with this problem, and some of the aspects around their journey in CLTI with their vascular surgeons that I think you'll hear about that will resonate around these issues. So why are we talking about this? Patients with chronic limb-threatening ischemia present lots of challenges to us, but just to summarize the main features here, they really do present to us with a very wide range of disease severity, from small wounds to very serious wounds on their foot with pain. They're disabled, and they present with a lot of individual complexity in terms of their other medical problems and the complexity of their vascular disease as well. And so what we're faced with is a really big educational challenge to help them understand a lot at once about cardiovascular disease, about the circulation in their leg, often about diabetes. It may be the first time they've ever had to deal with wound care. They may or may not have lots of previous experience with healthcare issues. And on top of this, they already often have significant other medical issues that restrict their ability to function, such as heart disease, lung disease, and others. We know that the treatment of CLTI can be prolonged. It can take more than one hospitalization, many clinic visits, often multiple procedures, lots of care both in the hospital and at home. It's very daunting, especially at the beginning of the process when you don't know if you're going to win or lose and you're facing a very large hill in front of you. And then when we start talking about what treatment options we want to propose, we actually ourselves have limited evidence to discuss that as far as how strong we want to push a particular approach. Often we are faced with just limited evidence, and a lot of it is based on our own personal biases. And the treatments that get offered to patients really may vary by where they go, which doctor they see, which kind of office it is it a hospital or an OBL? And so all of this really comes down to a very complex challenge in terms of how do you execute shared decision-making. And this little cartoon suggests that the 2 pillars of shared decision-making are, 1, informed consent, which means that the informed part is the education piece, really having patients understand what they're really signing up for in this journey, which, to save their leg. And then patient-centered care means that we have to work with them to understand what their goals and values are. What do they really want to get out of this? What do they think is at the end of this very long journey for them that makes sense for them and their families? And when we put those 2 things together, understanding their values and the process, we can really have shared decision-making. But this is a lofty goal in a disease this complicated. From our side, we've sought to structure the thinking around this, around separating the patient from the limb and then the vascular problem. So the plan approach summarized here suggests that we first take the whole patient into account. We think about how sick and frail they are. We think about their risk for anesthesia. We think about their overall mortality and survival. And then we look at their leg and we understand how severe or how acutely threatened it is. And only after all that do we look at the vascular problem itself and start to dissect out which treatment do we think is going to work best for them. And so this cartoon from our global vascular guidelines that attempts to show a workflow, and you'll see more of this later, really boils down to a couple of questions right from the outset. When you first see the patient, obviously the first question is the leg even salvageable, or is there already too much damage, too much infection to render a foot that's really walkable at the end of all this? So that's the first thing you often have to decide. And then after that, how severely threatened is it? This is something that I need to move immediately on, hospitalize the patient, or and bring them in to get started right away. Again, risk stratifying the patient and assessing not only their overall health, but what's their goals for function. Are they walking in the community, or are they already wheelchair bound? Are they someone who has a goal of being able to take walks or play golf, or is there someone whose goals are much more limited? And then after that, we need to define the vascular part of the problem. Where are their arterial blockages? How severe are they? Are they a candidate for surgery if necessary? And if so, we need to know if they have a good vein for a possible bypass, and then define a strategy for revascularization. And there's a lot of rubrics that one can apply here, but we know that there's no one answer for all patients. Some patients, or many patients, may be well served by a catheter-based approach, but some patients might need to go directly to open bypass surgery as the best way to preserve their leg. So it's very complex decision-making, and there's trade-offs in these things, minimally invasive versus durability, severity of the hospitalization versus ease of repetitive intervention. So the reality is that this cartoon really more aptly summarizes some of the complex journeys that patients go through when they start out with chronic limb-threatening ischemia. They might get an initial procedure, but often that's not the one or last one. And I'm sure that everybody in this room knows that most of the patients end up getting more than one procedure. They get an initial bypass or angioplasty, and then they're discharged, and then they start with the wound care and the follow-up and the clinic visits. And then it either goes in one or two directions. It either starts to get better and it resolves. And if it does resolve, we know that there's still a significant risk for recurrence. So patients need to be followed closely and reassessed. And so it's not like other types of surgery where you get a gallbladder removed and it's one and done. It's really it's a long-term relationship that the patients have to buy into. And they may need repeat procedures over time. And even when we get a successful result, surveillance is important and gets you back into the cycle again. So this is sort of the overall sort of pathway that many patients take different parts of this pathway, and we can't predict at the beginning which part of this pathway they're going to be in for a long period of time, but we have to make them understand what the journey is like. So to help us with some of these conversations around how practitioners approach this conversation with their patients and get them engaged in controlling their own destiny with their disease, we really have an outstanding expert panel of clinicians. Our current president, Dr. Mills, here on my left, Misty Humphreys from UC Davis, David Armstrong, podiatrist from USC and a leader in this field, Leanna Banyan from UCSF Fresno, Chris Abularaj from Johns Hopkins, and Bill Schutze from Texas Vascular Associates. All of these folks have tremendous lifelong professional experience with dealing with this in their practice every day, as many of you in the room do. And they're going to share with us some of their thoughts around how they approach this. So we're going to start out with a couple of brief talks. First, Dr. Abularaj will take us through how he uses staging and Wi-Fi to triage the acuity of the problem and provide prognostic information to the patients about what they're up against in the beginning. Dr. Armstrong will sort of tackle the same question from the standpoint of the foot side, trying to help the patients understand how much foot surgery they might need, how long they might need to be off their feet, and what it's going to take from the foot side to heal their leg. And then Dr. Humphreys will talk a little bit about identifying patients who may be very, very high risk, and how she approaches taking care of them with wound care and palliation as opposed to aggressive intervention. And then we're going to talk with our patients, our 3 Chicago area patients who I'll introduce to you after the lecture. So let's start out by asking Chris Abularaj to come up and kick us off. Well, the session is being recorded, so both from here and also from the floor, please make sure you get to the mic so you can be heard clearly and you introduce yourself when you're asking questions. Thank you so much.
So thank you, Dr. Conti and Dr. Mills, for having me here today. And thanks for everyone for waking up so early in the morning, especially after such a fun night last night. Okay, great. So I'm going to be talking about how I use Wi-Fi to triage acuity and provide prognosis, and basically to educate patients as to what this journey really entails. I have no disclosures. I think everyone's pretty familiar with the Wi-Fi classification. It's similar to the TNM staging of cancer. It takes into account the grades of wound, ischemia, and foot infection. And it's been shown to predict multiple outcomes. It's predicting major amputation at 1 year, time to wound healing, and also the benefit of revascularization. But how do you actually use Wi-Fi in your clinical practice? So acuity and prognosis, I think, go hand in hand. The worse the wound, ischemia, or foot infection, the sooner you have to provide an intervention. And it also allows a clinician to triage the category to treat first. If ischemia is really bad, but the foot's sort of stable and the infection's not, that bad, you can just treat the ischemia first. However, if the foot infection is severe and they have wet gangrene, that needs to be drained first. And of course, the higher the risk of amputation, the worse the prognosis. Wi-Fi also helps you in patient-centered care. Patients frequently lack a knowledge of peripheral arterial disease and CLTI, especially in the beginning of their journey. However, they do understand cancer stages, and they also understand colors. And I think while this schematic is very, looks complicated and there are a lot of permutations, telling a patient that green is good and red is bad actually sort of helps them frame, what they're looking at. So this helps frame the discussion around stage and risk of amputation and helps them to better understand their condition. And finally, it also helps in shared decision-making. Is the juice worth the squeeze? Sometimes you see a patient come in with severe ischemia and a really bad foot infection, and the foot, you're not sure if it's going to survive. And it helps them understand when limb preservation is really a long shot, and also how long it's going to take to get that foot to heal. So I thought I'd talk about a couple of examples first. So this is a patient who was a 68-year-old recently who presented with a small little left second toe ulcer. He had a failed kidney transplant, is back on peritoneal dialysis, and he's off the wait list due to this wound. So his family was very concerned that they wanted to get the wound healed so that way he could get back on the transplant list. We debrided the wound and all he had was this small little ulcer here on the second toe. He had an ABI that was non-compressible and a toe pressure that was 63. This is an initial Wi-Fi of 100, which is a limb threat of stage 1 or a low risk of major amputation in 1 year. The time to wound healing should be short and the benefit of revascularization should be very low. So it's low acuity and relatively a good prognosis. And when we walked him through the plan, what we did was we explained that we had a low risk of limb loss due to the Wi-Fi stage 1. So we began with simple wound care and then decided to see how it goes. And of course, with the Wi-Fi and the plan, you have to reassess the patients. So he came back and he had this little ulcer that sort of turned to gangrene relatively quickly. And when you restaged him, basically he was a Wi-Fi 200 at that point, with a limb that's now a stage 2, with the benefit of revascularization that's low, and a relatively low risk of major amputation still. But based on that change in the Wi-Fi, we changed the plan and decided to perform an angiogram. So here you can see some representative images. He had a normal superficial femoral artery and popliteal artery with what ended up being two-vessel runoff with some minor disease of the perineal artery. However, when you look down at the level of the foot, the anterior tibial artery occluded just above the ankle, and the posterior tibial artery was reconstituted by a posterior communicating branch of that perineal artery. So due to the fact that he wanted to get back on the transplant list as soon as possible, they tried to avoid doing a major bypass. So we did a little angioplasty of his below-knee popliteal artery and tibial perineal trunk. And here you can see on the completion angiogram, this is not occluded, this is an early image. And the point is that with that angioplasty, there was a bit better perfusion through the perineal artery with delayed flow through the anterior tibial artery. So we were hoping that that would somewhat improve his toe pressures. And if we could eke out a few millimeters of mercury, maybe we could get this toe to heal. And of course, we brought him back, we did a reassessment, repeated his ABIs, and unfortunately his toe pressure was a little bit the same, perhaps slightly lower within the standard deviation. But this now put him at a Wi-Fi of 210, which is a stage 3 limb threat, so a moderate risk of amputation with a moderate benefit of revascularization. So of course we had a change in plan and at that point decided that he just simply needed a bypass to his posterior tibial artery. And here you can see a representative angiogram of the completion angio. The posterior tibial artery bypass down to the foot, improved the perfusion. He underwent a simple toe amputation and healed that wound in a couple of weeks. So how do you use Wi-Fi to determine the benefit of revascularization? This is a patient, I'm sure you've seen very similar patients like this, a 60-year-old with left forefoot gangrene. He had a history of a major amputation on the opposite side. He had diabetes, end-stage renal disease on hemodialysis. When we did his non-invasive testing, again, non-compressible ABIs, toe pressure of 26, this put him at an initial Wi-Fi of 332, or a stage 4 limb threat, which is the highest. Time to wound healing is somewhere, who knows, 6, 12 months at best. And the benefit of revascularization, technically speaking, based on expert consensus, was high. However, the real question is, are you going to be able to save this limb? Because what you see on the outside is not necessarily what you see on the inside. So he had high acuity and a questionable prognosis. And if you look at the actual Wi-Fi paper that was published in 2014, they had this second chart, which looked at the estimated likelihood of benefit of revascularization for a patient presenting with limb threat. And of course, very low was green. This patient would be somewhere over here. It's high benefit of revascularization. But this was based on expert consensus. And this paper that was published by Dr. Mills and Dr. Conti is actually, I really like this paper. It's a little bit complicated, but simply put, what they did is they looked at the observed risk of losing your limb versus the predicted risk. They did a cluster analysis, and what they found was that there were 4 different revascularization benefit quartiles. And this one quartile had what they called questionable benefit. And who are these patients? These patients are patients who have a higher amputation rate despite the attempts at limb salvage. They grade 3 wounds with essentially no ischemia or severe infection in the setting of severe ischemia. So that was this patient here. He had a questionable benefit of revascularization. So we actually talked to him in terms of the plan. He was obviously higher than a Wi-Fi stage 2, but the question becomes, is he a candidate for limb salvage or not? Should he undergo a primary amputation? Now, a lot of patients don't want to undergo a primary amputation, but that's really the decision that they have to make, and they have to understand what is going to happen over the next year or so. So he obviously chose to try to save his limb, and we went along with that. So at that point, we decided to do anatomic staging with the glass classification. And here you can see, again, his SFA was relatively normal, a little minor lesion there in the mid-SFA, and then he had single vessel perineal runoff that went down to the foot with relatively small posterior tibial and dorsalis pedis arteries. So based on that, he was otherwise a standard risk patient. He had good vein when we mapped him, and so we decided to perform an open revascularization. He underwent a left below knee popliteal to posterior tibial artery bypass that you can see here, and then underwent a drainage amputation of his forefoot. What you can see is there's a bit of edge necrosis despite the revascularization. Ultimately underwent a guillotine transmetatarsal amputation, coverage with the dermal regenerative template. Here you can see a granulation tissue, and then ultimately underwent a split thickness skin graft. But this was 8 surgeries with the time to wound healing over 1 year. So I think it's really important that you use the Wi-Fi classification not only to explain to patients what their risk of losing their limb is, but also what it's going to take to save it. So in conclusion, Wi-Fi is a powerful tool that can triage acuity and provide prognosis. It predicts major amputation, time to wound healing, and the benefit of revascularization. Clinical reassessments are the key to successful integration of Wi-Fi into the plan and your practice. And patient education is a key component in shared decision-making and an important factor in achieving their long-term goals. Thank you.
Our next speaker needs no introduction, but I'll give a short one. Dave Armstrong and I worked together for a decade or so in Tucson with the Southern Arizona Limb Salvage Alliance. He couldn't think of any new acronyms, so I used the same one in California. But David and I have tried a lot to help build teams around the country, just of toe doctors and flow doctors working together. So he's going to, I think, contrast 2 patients who seem similar on the surface but might get different treatments.
Thank you to my Flomigo Prime. Are you subprime? That makes you so, okay. No, you're not subprime.
Co-prime.
Wait, that's nice. Co-prime is nice. Let's see here, and let me see if I can screw this up, ladies and gentlemen. Try to bring the quality down so that Dr. Abularaj looks even better, because that was a spectacular talk previously. But so, ladies and gentlemen, so let's look at this maybe from the end of the anatomic peninsula as a flow doctor, kind of a consumer living on the end of the kind of anatomic peninsula. But what we're going to talk about are things that all of us would see maybe in the emergency room, in the emergency department at our own place, maybe even on Monday. And we already talked about this to our patients. You guys are great. If any of this grosses you out, just avert your eyes for a few minutes. You guys don't have to avert your eyes. By the way, I can't believe there are so many people in here after that party last night. And,
you digress.
yeah, I will. I'll hustle. I'll make it. We got it. And I promise I'm going to make it happen. Why say it in 2 words when you can say it in 200, Professor Mills? But it really is life affirming to see all this stuff happening in that packed house 2 days ago. The 2 patients that showed up in the ED ended up in a manuscript that came out maybe a few days after the last one healed, and it's kind of a Dickensian, sort of a tale of 2 souls, because these are 2 almost identical patients that showed up literally talking to each other, families talking to each other. One of them was actually in a non-ketotic coma, but between the drapes in this emergency department at our hospital in Tucson, Arizona. But we're talking really about surgical and really personal decision-making, looking after these patients. So both patients were in their late 30s, early 40s. One was 38. The second was 42 years old. This first patient is the 42-year-old patient. He came in with a white count of 38, actually, coincidentally, and again, in a non-ketotic coma. We ended up taking him into the operating room immediately. And as you see here, gas gangrene, sort of unfortunately the whole enchilada, quite a lot of tissue loss plantarly, and this is running up his leg. But in talking to the family, because of course he unfortunately was non-communicative because of his really life-threatening infection, we talked to him about the fact that we could take him in for a second, third, and fourth look, just like you heard from Dr. Abul-Raj. But because of his job, not because of his blood flow, he had sufficient pulse, he had palpable pulses. We didn't actually run him through the non-invasive vascular studies. But because of his job and because he was sitting behind a desk at the Pima County Sheriff's Department, he could maybe withstand just a below-knee amputation, high-quality rehabilitation, and moving on toward healing. So that decision was made over the course of 1 week. Again, the very, very similar patient coming in the very same night. Again, both families became really, really close. This patient came into the OR, and you see this very, very similar sort of situation. Gosh, you guys, I know you can, you guys can deal with all of this purulence, but you see quite a lot of pus in the plantar central space infection. And you'll see this ended up leading to a fair amount of tissue loss. This is after the second look. And when you look at this, this looks really dramatic, but it's really not as bad as it looks, because plantarly, thank goodness, first of all, he had a toe pressure of 55, so kind of, and biphasic. So this was really an infection-dominant condition, maybe with a stage 1 on the vascular disease, but again, high risk for limb loss. But this guy laid tile for a living with his family, and still does. I'm going to bury the lead. Lay tile for a living. And if you have a prosthetic bending down at more than 65, 70 degrees, might make it hard to work and to function and to provide for his family. So we tried as hard as we could to preserve this limb, and you'll see this here. This is after just 90 days of a vac. So we did not do any free. So you would look at this and you would say, well, there's a fair amount of tissue loss. But again, if you look here, it's not as bad as it looks. You see plantarly, there's really quite a lot of glabrous skin there. And you can see the fifth ray will just kind of skip over, and the weight bearing will kind of end up in the forefoot out the hallux. So we could actually not even put free tissue transfer on this, although that's a really good option here. We actually just skin grafted it. I did. And Joe Fiorito, my fellow at the time, thought that, if one staple in the gun is good, just kind of test the LD50 for staples on the plantar aspect of the foot. And you know what? That looked pretty darn great. And actually, after just under 4 months, you'll see him kind of moving on to healing. And then after that, it's not over. We then rechecked. Again, you heard this already in the last talk. We rechecked his flow because these patients are evolving, and his flow deteriorated a bit, went down into the 40s, elected to do an AT angioplasty by my Flomigo Prime to my left. And then ultimately I just did an Achilles tendon lengthening, and then finally after that, do I have any pictures of, we actually did a little ray osteotomy, and then seeing this patient week after week, month after month, year after year. These patients are in remission. They're in vascular remission. They are in diabetic foot remission. And the goal is ulcer-free, hospital-free, activity-rich days for both of them. And actually, I will kind of give the coda to this whole thing. You know, I ended up last year getting a Christmas card, one virtual, one actual, from both of these patients. They're both still alive, kicking, doing great, part of our family. But one thing that toe doctors and flow doctors have in common, you'd say, what do these strange, odd bedfellows have in common, is that, you know, we really do look after patients from the alpha to the omega. It doesn't start and stop in the operating room or in the emergency department or on the wards. It's really all the way. It's not a lot of hit and run stuff. And this stuff can be both challenging for our patients, frustrating and rewarding, but I think in a lot of ways, life affirming. And ladies and gentlemen, thank you very much. It's been an absolute pleasure.
Thank you, David. Next up, Dr. Humphreys will share with us how she approaches some high-risk patients and offers them palliation and wound care in her practice. Misty.
Tweeting already. It's middle of the morning. Here we go. All right. Thank you very much for the opportunity to be here. This is an area that all of us got up at 7 o'clock in the morning on a Saturday to come and talk about. So clearly we're very passionate about this. So I get the luxury of talking about high-risk patients and offering palliative wound care. I love the idea that we have changed the conversation about how we talk about chronic limb-threatening ischemia, and that we've talked about it in this way that has become remission, stage 1, 2, 3, and 4. And I think also we have to talk about palliation because that's important to some of our patients. And these are my disclosures. So as everybody else has, we're going to start with a case. 97-year-old woman, demented, wheelchair bound, comes in with what looks like a small wound on her foot. Has gotten non-invasive testing, which shows that she does not have enough flow to her foot to heal. And she does not want an amputation, or truth be told, she's demented, so her family doesn't want an amputation. And part of the reason for that is because it takes her from being somebody who can stay at home, where she is with her family every day, to potentially someone who's going to have to be in a facility where she can move around, or she can have a lot of help, because it's a big strain to be a caretaker these days, and I don't think we always appreciate this. And so in her case, she did not necessarily have an option for revascularization. Is there a mouse here? No, there's never any arrow, but you can see her angiogram, and there's a popliteal occlusion with an AT that comes back. And multiple people had tried to open this in an endovascular fashion by the time that she had gotten to me. And yet they weren't able to get it open endo. So the thought was, am I going to do a bypass in a 97-year-old woman who's wheelchair bound and demented? And we elected not to. We actually elected to do palliative wound care. And over time she healed. So how did we come to that particular decision? This is where Dr. Conti talked a lot about these global vascular guidelines, and I like to give him a hard time about this. It's a 160-page document. This plan is on page 64 for those of you who need just a little guidance on where to get it. The other 100 and something pages, you may just gonna skip through that. But for patient risk, how do we do this? We think that we are so good. Vascular surgeons think we can look at patients and say, okay, this patient's sick, this patient's not, this patient's frail. There's an objective way to do this. So the SBS CLTI mortality calculator is something that I use. It's an app, it's on your phone, and so you can go through, and as you're sitting there talking with this patient, this is what it looks like in the calculator, or in the app. So you go to it, at the bottom it has these VQI calculators, which you see on the far screen, and then it moves through, and you put in the age, race, indication, and all of these things. And then it's going to spit out whether they're low, medium, and high risk. And this work is done, and the reference is in the calculator too. It's work that was done from VQI by Jess Simons years ago to come up with this. And so you can tell somebody they are, see, Joe Mills is doing it right now. So you can tell somebody they're low risk, they're medium risk, they're high risk, and that's a 30-day and the 2-year risk. And that allows you then to counsel these patients. And we've heard about Wi-Fi. I have laminated Wi-Fi papers in each of the rooms, or things that we keep in the room, because as Dr. Abuluraj mentioned, color is something they understand. They understand the word amputation, and they understand green is good and red is bad. And so we have these in the room so that I can then go around or go through them with the patient. And on the front, we talk about what they are, and then I can circle these with a little marker, and a red dry erase marker on the back. And we talk about, you're in the red zone, you're in stage 4 disease. And the final thing actually that I got while I was here is, we've also heard about this glass classification, but on Wednesday at the VQI meeting, they handed out these glass classifications for the VQI as well. And so now I'm gonna take those back and laminate those and keep those in the room. Because when you're going through this with a patient, you actually then get into the staging of disease. You have stage 1 disease, you have stage 2 disease, you have stage 3 disease, or you have stage 4 disease when you're thinking about Wi-Fi. And I've heard Dr. Conti talk a lot about this, and I've heard other people. Stage 4 disease to me is something that I have now decided I'm gonna admit that person to the hospital, or I'm gonna expedite their workup, where I didn't used to do that. We've all done a lot of work, and we know how hard it is to get patients in, and the challenges that they face. But I never really thought about, okay, this is a stage 4 disease. This needs an expedited workup. We're going to admit them. So in this particular patient that we're going through, she had stage 3 glass. She was in the femoral popliteal IP grading. She comes up with stage 3. And there's clear data that shows that endo in these patients does worse and open does better. But she is 97. So am I really going to do an open bypass in this 97-year-old patient? And while we have spent a couple of years now talking about best CLI and basal and open versus endo, this is not actually the question that a lot of patients need. The question is, do you need limb preservation versus amputation? And so how do you come to that? There's a lot of algorithms. You got plan, and now you got share. Share is the shared decision-making algorithm. You seek out your patient's participation. You help them explore and compare treatments. You assess their values. You talk to them about what is important to them. You heard Dr. Armstrong talk about the person who's, laying tile versus the person who's standing at a desk. And then you reach a decision with that patient. And this all takes time. And you evaluate your patient's decisions and you come back to it. So just like you restage with Wi-Fi, you restage with, or you reevaluate what your patient's decisions are. We know that whenever you have these high comorbidities, or you're living in a nursing home, the life expectancy is lower, and we also realize that the outcomes are worse. Poor functional status is also something where, when you have vulnerable patients with poor functional status, their functional decline after any intervention, especially a big bypass, is going to be more significant at 1 month and at 1 year. And I cannot stress the poor nutritional status of a lot of these patients. We like to think that they are doing okay, and we like to look at them and look at that, but you need to get iron levels, you need to get albumin, pre-albumin, and all of these things. And we don't always, because it takes time and it takes a lot of effort that we don't necessarily get paid for or get the luxury of having that time for in our clinics. There's also this inability to comply with wound care. It seems easy to tell a patient to put dry gauze between their toe and wrap their foot with gauze, but there are so many reasons. They are unhoused, they are unemployed, they're socially isolated. There is a lack of health literacy, and that is not intentional in any way. It is complicated. I do not know how many times we say, my trainees or my nurse practitioners will say, well, we taught them how to do it. Did you sit down and walk them through it, or did you just tell them what to do? And there's a big difference there. And this is quite stressing to these patients. On Wednesday, we heard a talk about the psychological factors and the qualitative work that I've done with this and some other people have done. And so it's a big deal. So I came up with a new plan, and it took me a long time because I'm not nearly as savvy as, with acronyms and stuff. So palliative limb adjunctive normalization is my new plan for whenever we're doing palliative wound care. You palliate, your goal is to relieve the symptoms, but you need to still maintain some functionality. They need to walk, or they want that. Decreasing odor and minimizing infection risk through use of betadine, and then focusing on their nutritional status, because you can reassess them and decide that maybe they are a candidate for something, and then normalize the fact that it is okay to not want an amputation, and we will still take care of you. And so in conclusion, share your plan, start with a plan, I should say, and then do shared decision-making through that algorithm. But realize that palliative wound care is there for you as an option to improve quality of life and support these patients. And then, of course, you can always reassess from there. So I'll sit down, and then we'll take questions at the end of the panel. So thank you.
Thanks so much, Misty. That was really awesome, and gives us a lot of food for thought about the practicalities of offering patients that option, which many patients really benefit from. You got socks too? Oh, you forgot your word salad. Okay. So now what we'd like to do is talk a little bit with some real patients. So we're really, really fortunate and really appreciative to have 3 patients with us here this morning to share a little bit about their journeys with CLTI. They're patients who are cared for by surgeons here in Chicago. Dr. Ho and Dr. Milner were gracious enough to talk with their patients and see if they'd be willing to share with us a little bit about how this all shaped out for them. Maybe we can have someone help them up onto the stage as we get ready to talk about this.
Okay.
We did have a little session beforehand to chat, so this is not going to be a total surprise to them. They know a little bit about what will help us understand some of the challenges from their perspective. So again, thank you. We have Kathy Posner, Richard Bathji, and Dwight Taylor. And I know a little bit about their stories, and I know that they are quite representative of some of the problems we're talking about in terms of the complexity of the surgeries and hospitalizations that they've faced over the time that they've been managing this problem. And also, they're very, very fortunate to have incredibly dedicated vascular surgeons that have established lifelong relationships with them, which, as we know, is really what this is all about. This is about long-term care. So I really, this boils down to pretty much one question, but what I've asked them to maybe think about sharing with us is at a certain point in their journey when they were faced with perhaps how serious this problem might be for them, and what their future might look like if they could save their limb or not save their limb, and what kind of treatment options they may have been presented with at the time. Really what I want to know is how well did you feel informed? How did you get the information over time to help you understand what your vascular health problem was? And how did that interaction go over time with your surgeon to help you understand wherever you started with this journey and to what you had to deal with as a patient, and also for your caregivers and your families? So a little bit about your reaction to understanding the magnitude of the problem and some of the choices you were faced. So maybe I'll start on the outside with Dwight, share a little bit of some thoughts around that, and then we'll just move in and then we'll go from there.
Good morning. Guys hear me? Okay. Hi. Everything I was told about my surgeries I was very well informed. Had the right leg and the left leg done. Got to the point where I would get cramps, very bad cramps in my legs as I'm walking. And after I went to see my primary doctor, they sent me to Dr. Ho, and she's been jamming ever since. 2 surgeries, 4 years later, still kicking so far. But everything was very well explained to me on what needed to be done as far as me being okay. So far, so good.
So Dwight, let me just ask you quickly, were you shocked when you first found out that you had a bad circulation problem in your leg, or did you have some inkling that that was what it might be?
Well, the wife and the daughter both are RNs. And the wife was at Shirley Ryan, and she said, "You're not getting good circulation. You need to go see someone." So I was kind of, prepared for it because they were bugging me. So once they got through bugging me, and Dr. Taduro sent me to see Dr. Ho, she explained it after I did the compression tests or whatever they call it, however they call that procedure. And once they said how the flow was going, I was satisfied. She said, "This is what I need to do to make your calf stop cramping," is what happened. So far, so good.
Richard, you'd like to share some of your experience with how you initially faced this problem?
I've had both legs done. They were like, my right leg was done 2 years ago, I think. And my left leg was done about 2 months ago. And it was just a matter of waiting for it to get to the point where it needed, where it had to be done. I've had 6 or 7 diabetic ulcers on my feet. And the last few years, they haven't been healing. They take forever to heal. And it was because of the blood flow was not there in my feet. So we decided to go ahead with the procedure. And both times, everything was explained to me very well. The second time, I remember better, but that was, either an option of a bypass on my left leg or a blowout of the femoral artery, which is what we did. And I preferred that much over the bypass because it healed so much faster. Within a month after I was done, I was doing stairs, I was walking, doing everything, and when I had the bypass, it took at least 2 months, maybe more, before I got to that point. But everything was explained to me very well about what the procedures were and what to do. And it was a little bit up in the air because they had to wait till they got in and did the angio to see exactly where my leg was, what was going on, my artery. But they decided to go with the blowout on the second one. And I personally preferred that much because it was just easier to recover from, a lot faster.
I have one question for you. So you had multiple toe ulcers on both feet over time? Is that right?
Pardon me?
You had ulcers on multiple parts of your foot on both feet?
Yeah, I've had 6 or 7 of them over the years. And
Did some of them heal over time, or did they just persisted?
But sometimes one took about 1.5 years. I still have one that's just about done now. There's just a little pinhole on it.
And how many doctor's visits do you think you had for each one of them? How many times did you have to come in for some kind of wound care or some assessment, or did you do a lot of this treatment yourself?
I can't understand.
Did you do a lot of the treatment yourself, or did you? go
Yes,
to the
I
office?
did a lot of the treatment myself. I'm very good at wound care now. Because I'd see the doctor once a week or once every couple of weeks, but the rest of the time it was me doing it because I lived by myself, so.
Did you have to spend time in the hospital for any of them with infection or complications?
After the surgeries I did.
Okay.
3 days, I think, for both of them. I spent
Thank you.
afterwards.
Just curious, was there any really serious point with either one of your legs where you were worried that it might not even work, that you might be faced with losing the foot?
No, it seemed like the way they were watching it, because I went in every 6 months and they'd check and see where everything was at. And they'd say, it's not quite yet, but maybe next 6 months, you know. And I felt like they were monitoring it really well. And I don't know. I didn't think I would lose anything. I still don't, you know what I mean? This one that I did 2 years ago, that they did all plastic tubing from my groin all the way down to my ankle, just about, because they couldn't find a good vein to use. And that's still clear. I get an ultrasound every 6 months, and it's been clear for the last 2 years. And this one's doing well too, so.
Kathy?
I feel good about it after watching all these pictures and everything. I'm starting to wonder,
Right.
you know, what's gonna happen later on.
Well, we're glad that we
Yeah,
made
thank
you feel
goodness
better.
I was warned when to avert my eyes. But I really found the speakers very interesting, even though I couldn't understand everything to the depth of what they said. I understand a lot of it. My first diagnosis was 22 years ago. And Dr. Ho was so young then, she wasn't my vascular surgeon yet. I got her after my first vascular surgeon had retired. So it's been 22 years, probably one surgery a year, because I've been in like 20, 21 times to Northwestern. When I walk in, they go, hey, Kathy, just like in Cheers, Norm, you know, at the bar. But one thing that I think is important maybe for me to share with other doctors of something that's so spectacular about Dr. Ho's office is I don't have a relationship just with Dr. Ho. I have the relationship with the scheduler, with the nurse practitioner, with other nurses. So, you know, she's very busy because she's doing other surgeries. She can't spend her whole life caring about me, which would be nice, of course, but it's not going to happen. But the relationships being set up with other people in the clinic or the office, I think is so important. And I don't know how many of you do it that way to make sure that the patient knows, here's this person, this person, this person. You know, it's like sometimes I don't see Dr. Ho till I'm in the hospital for a surgery because her office is taking care of everything. And that's really important. And that's what makes me feel safe, because I can call with any kind of question, knowing that the nurse practitioner or a clinician can give me the information that I need. Or they'll say, we will check with Dr. Ho. But I can reach somebody like in 5 minutes. And that's very important. And I just want to give another shout out to how incredible Dr. Ho is. Normally, I would not get up at 5 o'clock in the morning. And when she called and asked me if I would speak, I said, sure. And then she said, oh, by the way, you have to be there at 7 a.m. And it's like, oh my God, I already said yes. And she
That
does-
was informed shared decision making.
Some of us,
Yeah, that's right, yeah. And also the respect that I have for her shows in that I get called all the time to participate in studies from vascular department, Northwestern, and with Dr. Ho, and I participate in every single study except the ones where you might have to take a pill, because then I'm too afraid to be like a guinea pig on that. But it's the relationship is so important. I know you hear it all the time, or people will say to you, I have great relationships with my patients, but you might not really know that you do. You might think as the doctor that you have a great relationship, but you should always ask the patient, is there anything else, we can help you with? And so I think that's all I have to add to it, and I'll take questions.
Thank you, Kathy. We're gonna ask Doctors O'Banion, Abularaj, Humphreys, Bill Schutze to come and join us up on the panel so we can have a discussion a little bit about approaching different styles of approaching this conversation. And I wanted to, there's a lot to digest here, and thank you all for sharing some of your experiences with this complicated problem. And you are fortunate to have these outstanding vascular surgeons taking care of you, no doubt. So, from the standpoint of the vascular surgeons sitting here in the room, listening in the room, and thinking about how you approach these conversations with such a wide range of people who come to you, some of whom are completely alone, some who have family members, some who have had previous experiences with cardiovascular problems, some who didn't even ever know they had such a serious problem. I'm just interested in your style. So, Bill, maybe we can start with you here. When you're first seeing a patient with a real serious limb-threatening problem,
No, thanks.
how do you begin to approach that, and also how do you talk about their options?
Yeah, excuse me. Thanks, Mike, and thanks for mentioning the word style, because I think style is really a part of how we all communicate, and style is not something that's measured, and there's no outcome metrics for style. But personally, I'm really, when I encounter a patient for the first time, I'm just trying to establish that trust relationship. I'm taking a lot of time to evaluate the body language, all of the people in the room, the family or the lack of family. And then where I practice, really trying to understand what language issues there might be. I see people that, many people where English is not their primary language. It may be Spanish, it may be Vietnamese, it may be Urdu. So all these things I try to take into account as I'm doing my evaluation. And then really trying to figure out how's the best way to develop that trust. So as we move forward, the patient and their support people can feel comfortable that they're getting a solid recommendation, whichever way we go. And so I think just trying to build that trust.
Thanks. That's an outstanding framework around the importance of trust. Leanne, when you're seeing a patient with say a really advanced problem, just de novo, first office visit, it's so much to take in. Just give us a little idea about how you try to get them through understanding the seriousness of it, and how you use maybe staging to explain to them why it's something urgent or not urgent, or share a little bit of that.
Yeah, I mean, I think that with these patients, the most important thing to do for me first off is to figure out kind of what their level of health literacy is, because I think every patient's going to be a little different. Some patients may not even know that there's a difference between an artery and a vein. They may not even know if the entire forefoot is dead, that they have a problem. And so I think first off, I kind of just ask my patients first off, what's your perception of what's going on? And get an idea of what they think is going on. And then the other thing, I think most of the reason why many of us went into vascular surgery was for that kind of longitudinal care. I kind of think of my patients like my vascular family, because I see them year after year after year. And so I treat them just as I would want to be spoken to if it was my family member, and just letting them kind of go through the journey together and make them feel like we're in this together. And so no matter what the outcome is, we're going to get through this, and they're not alone.
Can I sort of ask a little bit on that? Because we've talked about two different styles. And as I'm sitting here, my question and listening to the patients too, when do you bring up the worst outcome? So I sometimes feel that I need to bring up the worst outcome in the beginning as I'm building that relationship so that they understand we're trying to avoid that worst outcome. But how do you talk about the worst case scenario and build a relationship with somebody that you don't know also, if anybody on the panel can?
No, I think it is very important that patients understand the range of how this can end up from the beginning, so that they're not misguided around how serious it is, and also what could happen. But also there's this tendency to just get focused right on the foot and forget about everything else, their diabetes control. Are they even on the right medications for their cholesterol? Are they smoking or not? Do we need to talk about their cardiovascular health? There's so much to get into. Joe, maybe talk a little bit about that. Like, how do you start out with the overall assessment of the patient, rather than just, getting so incredibly myopic on just the foot? The foot's connected to the person, and some of them come in really in really ill health overall. I mean, it's obviously quite a range.
And not to digress, but back when I trained in the Air Force, the patients were all admitted to the hospital for the whole week, all the cases. And we would actually bring the patients to the room and show them their angiograms and go over their anatomy with them, and the interventional radiologist, the vascular surgeon, could talk to them. But having the patients here this is the first time I think we've done this. I think it's great. But But I try to get to know them a little bit, see where they're from, what their family situation's like, if they have difficulties in transportation, what difficulties they've had getting there. Then I do try to get an idea of how much they already might understand about what they have, because some patients they'll have a neuropathic ulcer that's not infected and they're worried about infection or limb loss, and they really is something that's quite easily treatable usually, and they need reassurance. And some other people know they're faced with limb threats. So I try to get to know the patient better, and I like it when there's family there, because having another set of ears. But I try to get some kind of relationship and show empathy up front, and then I use Wi-Fi, but I don't call it Wi-Fi, but I talk about, what's your primary issue with trying to save your foot? So once we get to the point where it's clearly a independent living patient, then I talk about the different components. Like, you have a large wound in a bad location, or you have a small wound, but there's already infection, we're gonna have to bring you in the hospital. But it's not a one-time deal either. I think you have to continue to try to educate over time. It's a long process.
Yeah. Chris, I mean, the notion that I've got this small wound on my foot, how is it possible that this could lead to me losing my whole leg? I mean, it just doesn't make any sense. What are you talking about? How do you, that's obviously a real big challenge. Some people are just shocked that this is what it could be. They barely noticed that they had a problem. How do you sort of work through that conversation a little bit at the beginning of this journey, and without scaring them too much, but just, getting them engaged and the trust factor?
So in my clinic, at least, the way I talk about things is very visual, right? Because you're presenting them with this idea that they have stage 4 cancer, right? And then once they hear cancer, they don't hear anything, zero. The family members may hear something, but if you're sitting there talking to them, they just no longer hear anything. They just hear cancer, cancer, cancer. So I do my best to try to explain the disease, use the Wi-Fi red, green type thing. And then the other advantage nowadays, sort of like Joe was saying, is that I go through their angiograms with them. So that way they see, okay, well, I have this small little ulcer, but on the inside, I have a really bad problem, right? And that's why we're talking about an issue. I would love to hear from the panel on that side, how you guys feel when, whether you want to hear the first time around that you're at risk for losing your leg, or do you want to be eased into it? Because when I see patients, everyone has a different style, right?
Is being a little scared helpful to get people to understand that you really got to start taking care of yourselves, or can it turn you off from even wanting to go to see the doctor because you're afraid it's going to end up in a bad way? I mean, it's a fine line. Did some of you feel like it was important for you to get a little shocked to understand that you really had to deal with this?
Well, as I've already said, my journey now has been going on 22 years in vascular, so I can't remember everything back from the beginning. I don't have diabetes, so I don't have any foot problem. But if you're asking, yes, I believe you should scare, but in a not too scary way. Because a patient does need to know that they should be eating particular foods, or be, going to rehab, or not smoking, or not. But you have to do it gradually and just very carefully. But I think you do have to tell them that there's the possibility. Dr. Ho told me recently about the possibility of losing my leg because my femoral artery has been blown up so many times in the past 20 years. And I said, I don't want that. And she said, we'll do everything that you don't have to. But at least she shared it with me. And I think that was real important that she shared it with me.
Dwight, you've got 2 nurses at home, probably.
Oh, well.
You said you have two nurses?
Yes,
In your
wife
family?
and daughter. No, fear is not an option with me. I was an elevator man at Sears Tower, so
Yeah.
I get to ride on top of the elevators and hang from the bottom while you ride inside. So fear wasn't an option, but I've been shot twice, stabbed once, married 3 times. I'm still here.
Having bad is nothing.
That's the bull. That's Taurus.
Okay.
Oh, my God.
I'm curious also to ask you 3 about, was this the first time that you even heard about vascular surgeon, or what a vascular surgeon even does? How did you how did you end up getting directed to a vascular surgeon? Was that something that you understood, or did you really, who'd you think you were going to see for your problem?
Okay, well, for me, I hadn't been to a doctor in 8 million years, and, because I was a very hardworking person. And I then realized that I needed primary care physician, so I got a primary care physician, and I was having trouble walking. You know, I would walk a little bit, I'd have the pain and have to stop. The first primary care physician I had, when I told her about the pain, she looked at my legs and she said, your legs look fine, there's nothing wrong with you. And I knew she was wrong, so I actually waited 2 weeks until she went on summer vacation for me to be able to see another doctor in her office, because I was afraid to fire her while she was around. And the other doctor in the office immediately knew that I had blockage, and he set up an appointment. His office had an appointment with me at vascular, and then immediately, I had Dr. Pierce then. He was around a million years. I don't know if any of you knew Dr. Pierce. And we had a great relationship. He retired on me, not fair. But I then got the most wonderful Dr. Ho. So my care didn't stop for a second. But I was never scared. I don't know why. But I wasn't, and still not, because I have faith in Dr. Ho. And you've all heard that. So if you hear that she's trying to amputate my leg, don't let her do it.
Rich, either of you guys have any reflection on how you ended up in a vascular surgeon? Was that right away, or did it take you a couple of times around the block with your primary care doctor to finally get a referral? Or?
Yeah, my primary care is a gerontologist, and she's got a whole team underneath her, and she recommended Dr. Milner when I was starting to have problems, and I hooked up with him. Like I say, he just monitored me all the time, did the blood pressure reading, everything, and says, not this time, but maybe 6 months, he'll be ready, and we did the first one, and then the same thing with the second one a couple of years later. But I don't know, I never had any fear, because I have faith in her, and every doctor that she's given me, I've had a cardiologist, endocrinologist, you name it. And they've all been good for me.
So David, you've promoted with many of us the team concept about taking care of these patients as a team. But I'm just wondering, there's a big crowd sometimes in that clinic descending on the patient. It can sometimes be a little overwhelming. There's somebody changing a dressing, there's someone listening with a Doppler, there's people talking about the foot, there's people talking about the arteries. How do you get a sense if, it's just, we're getting what we need done, but they're walking out bewildered? You have to ever put it back together again after all the chaos?
Well, that's a great question. And by the way, even if that wasn't a great question, I would say that's a great question. That's a great question. But Mike, I think that, this is an easy question to answer from the podium, and it's hard to do in real life. But the point is that every patient, you got to meet her or him where they are. And also, you have your therapeutic spouse, but you also have your vascular, your toe and flow spouse, and you have the nurses and the other team members, even dietitians and prosthetists, orthotists, and everyone's a little different, and everyone communicates a little differently. But, I think just like the politicians say, it sounds crass when they say it, but maybe a little less when we do. You got to stay on message. And if one of your trainees, again, another member of your family, says one thing about maybe a possible therapy or outcome, or another medical student says another thing, just talking to them and making sure all of them are communicating with the patient really well, because they're going to probably spend more time than you are. But also, and again, this is really hard to do, especially when we're all busy in the OR and clinic, but pulling up a chair and really just caucusing with the patient and their family. Because my pop was a toe doctor and passed away about 20 years ago. Smartest guy I ever knew. Said, I thought I belonged on a poster when I was a teenager, and he used to tell me, folks don't care how much you know until they know how much you care. But I do understand what that means now, for sure.
So Bill, it's a challenge everyone's got time pressures. You got an office full of patients. You didn't know you were going to be dealing with someone walking in with a really bad problem. And now you can't just rush out of there. How much of a staff needs to be capable of helping out with some of these discussions so that, how does it work in real life? It's a lot of pressured conversation.
That's a great point, Mike. And there's challenges working in a private practice setting in regards to being able to use a multidisciplinary team to take care of very complex patients. And in our situation, and in many people that are out in the community, and I see Dr. Molnar there, care is really siloed, compartmentalized, and it's not a one-stop place like a nice limb salvage clinic can be. So we really have to rally our own office to do the best and elevate the awareness within the office to our patients that have critical needs, like limb-threatening patients, and augment the communication between the patients and our staff and the physicians. We try to leverage telecommunications as much as possible to limit the needs of the patients to come to the office repetitively, monitor them remotely, and get wound pictures sent in every time the home health nurse sees. So it's just raising that awareness within the office to overcome the barriers that we have by not being able to have all the caregivers necessary in one space for our patients, and still be the quarterback, making sure they're getting their wound care and that they're getting all their other needs met with their endocrinologist and their primary care physician for their blood pressure and lipid needs, et cetera.
Well, we're at 8:15. I just want to reflect that, we do have these three patients here clearly have been engaged over a long period of time and are fully engaged in being part of taking care of their own problem with their surgeon. But it takes time to get patients to that point. And I think what we're trying to talk about here and help all of us figure out is not to forget that. First of all, we get focused really quickly on the technical challenge of trying to deal with the surgery that's needed and fixing the blood flow and fixing the foot. But without the patient as a partner and without understanding, what they're facing at home with this and what they want to get out of it, it's a difficult thing to accomplish because it requires a buy-in of the patient, and the trust of the patient has been pointed out. So I think with that, I think this was meant to just be an opportunity to discuss how rich this problem is. We really, really appreciate you guys, the three patients this morning. Thank you so much for joining us.